Uh, Congenital vertical talus. So it is a rocker bottom deformity with a convexity towards the plantar aspect. The talus is dislocated and is vertical to the tibial axis and is mishappens and placed in the at the plantar aspect. There is a dislocation of the talonavicular joint. The navicular bone is dorsally placed and the talus is plantar at the plantar aspect. On clinical assessment, there is a calcaneo valgus deformity of the foot with the cavus. On clinical examination, it is rigid. At palpation, it's possible to feel the navicular joint, navicular bone, which is placed at the dorsal aspect. There is contracture of the dorsal structure, that is muscles, which consist of tibialis anterior, extensor hallucis longus, extensor digitalis longus, as well as sometimes peroneal. Regarding history, I would like to know when this deformity happened. Was there a congenital association? Is there any syndromic association, that is arthrogryposis or a Larsen syndrome? I would like to exclude a congenital oblique talus with a vertical talus, and there is a difference which is of significant importance. I will do a AP and lateral view, especially with a plantar flexed lateral view, to find the Meary's angle. Meary angle is basically a line drawn for the first metatarsal and a line drawn at the talus. The angle is normally 0 to 4 degrees. This angle is increased in congenital vertical talus. Moreover, at plantar flexion, this angle is reduced in congenital oblique talus itself, and the talonavicular joint is aligned. The treatment of this is a reverse Ponseti casting, basically physiotherapy and stretching of the dorsal structures to improve the deformity. The surgical intervention would consist of lengthening of the dorsal structures and K-wire fixation of the talonavicular joint and sometimes calcaneocuboid joint. The soft tissue structures which have to be released is ankle joint, talonavicular and calcaneocuboid joint, tibialis anterior, and extensor hallucis longus, extensor digitalis longus, and sometimes peroneal. After the reduction, a K-wire is passed through the talus to the first metatarsal angle, first metatarsal talus to the first metatarsal, and it's reduced. The navicular ossifies at age of 4, which is not visible. That's why Meary angle is utilized, as navicular bone is parallel to the first metatarsal